Good morning, John Adamson, the rehab and documentation guru. I was just going to comment on the sun, but then it got blocked. Don't mind the massive sunshine in the background, but it is a beautifully crisp morning here in Fredericksburg, Virginia. I am getting ready for the day, and I thought I'd share with you, as I've done in the past, a note to a doctor. So I'm going to avoid one item that can be construed as HIPAA related information. That would be the age, specific age of the patient. So I had a patient yesterday and I ended up evaluating him only. And anyway, I'll just read the note to you. This is how I document it. Use it as you will, as an example, as gleaning some information that's imparting my knowledge as a therapist to communicating with the doctor. So I sent this note to both his vascular surgeon and to his primary, who's his home health attending. Doctors blank. Dr. Blank ordered home health PT for this 50-ish male with PAD, status post left AKA. My evaluation reveals good left residual limb range of motion strength and non-atypical phantom pain. I like that little coupling, non-atypical. In other words, meaning he's got typical. I have no idea why I worded it that way, but he's got typical phantom pain. Wanted to say something about that. Obviously, if you've worked with amputations, you know with above knee, above knee. One of the things we often see is patients will develop tightness in their hip flexors, and they'll actually get tight into abduction because of the cutting of their adductors, so many of their adductors. So he had really good range of motion, which was excellent. Anyway, let me continue. He is performing all his home exercises from the rehab well and should be a good candidate for an AK prosthesis when he heals distally. My concern is his intact limb. So he was going to his vascular surgeon today, and so I wanted to have this note sent out. He has significant signs of distal lower extremity vascular compromise, including the following: thickening of the nails, significant dryness of the skin, callus formation in some non-weight-bearing areas of the foot, calf intermittent claudication after only 2 to 3 minutes of standing, significant distal weakness worsening as testing more distally, reports of distal sensory loss. He reports medical follow-up with vascular surgery today. Due to his significant arterial insufficiency of the right lower extremity, he is not recommended to advance beyond his current functional status of independent transfers without a device and use of a wheelchair. I've taught him some desensitizing activities of the residual limb. Therefore, prior to his receipt of a left AK prosthetic, he does not need additional PT. After he receives the prosthesis and undergoes a bypass procedure, which is a plan for him, especially to make sure his right leg doesn't become necrotic like the left one was, his PT rehab needs are expected to be extensive. Patient is in agreement with this plan. So anyway, just a little note to the doctor. I'm concerned that when he goes to see the vascular guy is mostly going to be just looking at his healing stump, which, he operated on. And, maybe talk to him a little bit about the bypass, but not give a lot of attention to the remaining leg. And this guy has a lot of concerns. One thing to keep in mind with your patients that have vascular compromise in their legs: don't make them pound on that leg. This is not a good candidate to advance gait training with one leg and use of a walker. He's lucky so far. He's not lost this other limb. It's probably a matter of time before he becomes a bilateral AK. But I'm hoping vascular surgery will be able to salvage because he's got a massive clot. But anyway, hope you're having a great day. Take care. God bless.